Ready to rock and roll.
Okay, let's do this. Hey, everybody. Welcome. Thank you for joining us today. And if you're listening to the recording a little bit later, thank you for listening today. We are excited to provide you with some of this content. I am Angela Love-Zaranka, Program Director for Lactation Education Resources. I have been a hospital-based and a private practice lactation consultant with over 30 years of experience, and I've served on the IBLCE Board of Directors. How about you, Sekeita?
Thank you, Angela. So I am a family nurse practitioner, a former labor and delivery nurse, and birth doula and lactation consultant. I've been working in maternal child area for over 25 years now. Had experience in the hospital setting, in the community setting. I also have a background in teaching nursing students. And so I am so glad that you've joined us this afternoon so we can get you ready for this exam.
Excellent. Thank you so much. So we are going to be just a quick overview of what we're going to cover. This webinar is sometimes a little bit long. We have content we want to provide to you, but also we'd like to answer questions. We'll be answering questions in the chat, but also we will answer a few questions. They'll be flagged and we'll answer them at the end. So we're going to be reviewing a few key concepts in different areas of the detailed content outline. The topics which are presented are based on the candidate's performance, and we chose ones where people usually have the most challenges. So we are going to have a chance for you to test your test-taking skills. We're going to have a few multiple choice questions. And finally, we're going to review a few test-taking strategies and emphasize on what you can do for yourself before, during, and after the exam. So first, just a little bit of housekeeping. Asking questions in the GoToWebinar platform is easy. If you're on a desktop, this is where you'll find it. Take a look at the blue arrow there pointing to the questions box. And if you're on a mobile device, it can be found along the bottom bar of the app, and you'll see this question mark here is pointed out by that green arrow. So we have a couple of wonderful folks here on our call today who are providing a little bit of customer support. We have Amy and Kim. Both are IBCLCs who've taken the exam recently and are a part of our fabulous support team. Jill is from our tech team and is also on the call. So if you have any tech issues, please type them into the question box and Jill will be more than happy to answer any issues that you may have. Please do not photograph or record this information with a camera, phone, or any other equipment. We're recording it and you will be able to review the session many times. As I mentioned, a few of the questions are going to be answered by Amy and Kim during the call. However, there are some that are going to be flagged for everyone. So we will probably go over this 90-minute session, but if not, then that's wonderful. But if we do, just wanted to kind of give you a little heads up so you can be prepared. Okay, so we are going to start with medications, and I'm going to turn it over to my esteemed colleague, Sekeita Lewis-Johnson. Sekeita?
Thanks, Angela. So yes, we're going to begin with medications, and really and truly, this is an overview. So it won't be in any in-depth, but I do want to assure you that the handout will include the slides regarding this part, so the medication key points and all of the medications that we're going to review. So rest assured, you really don't have to do a lot of writing during this time, but wanted to let you know that we do have a handout attached that you will be able to take. So let's get started. All right, so key points to remember about medications is that the amount of medication that's usually excreted or enters into milk, in human milk, depends on many factors. You know, the first thing we're going to talk about is the milk to plasma ratio. And this is useful to evaluate really the concentration of medication in the maternal plasma compared to the milk. So if there is a high ratio, then the medication will enter easier, okay? One of the significant and one of the most significant safety parameters regarding human milk and medications is the relative infant dose. This is used to really assess how much would the infant get if provided this much of milk based on this medication is in the mom's milk, right? Or the lactating person's milk. So it's usually expressed as a percentage of the maternal or lactating person's dose. Okay. And according to HEL, medications with a relative infant dose less than 10% is considered relatively safe for a full-term infant. And notice I said full-term infant. I want to just really point that out, because if there was a question about relative infant dose, and let's just say that it was regarding a baby who was maybe a micro preemie or a preemie, right? You might want to think about what the question is asking you in relation to this relative infant dose. And so really the 10% is for full-term infants. And if it's greater than 10% for a full-term infant, there should be cause for further assessment and caution used, okay? Also, keep in mind that medications can only enter the milk compartment from the lactating person's blood. So what that means is when medications get into the bloodstream, it can pass into the breast milk. During the first initial days, right after birthing a baby, the colostrum phase, usually the transfer of medication into milk is high, but the total dose that will be transferred to a baby is lower, basically based on the fact that babies are not getting a ton of colostrum. But then the maternal piece to that is imagine, and this is what I like to say, like imagine that you have a big bucket and you put like 3 marbles in that big bucket. There's like all these gaps and holes at the bottom of that bucket, right? That's kind of how the alveolar gaps are, right after delivery. They're still wide. Now imagine you put maybe 500 more marbles in that bucket. There's very little spaces between, so the gaps are fully closed. And so that's a way to kind of visualize the concept of, during the colostrum phase, transfer of medications into milk could be high based on those large, wide gaps, right? And so, for visual learners, that might work. For linear learners, you may be like, nope, that didn't work for me, Sekeita, and I'm okay with that. All right. So additional key points to remember that most drugs will enter the milk at really insignificant levels, clinically insignificant levels, which means that they clinically don't really do damage or harm, right? One of the biggest ways to determine levels in milk is to really, again, refer to the relative infant dose and also lactation risk categories. Now, in saying this, there are different ways that different references categorize certain medications. So for example, if you're looking at HELs, you're going to see it as an L1, right? They're an L5, but in other references, you might see, for example, some of the studies, some of the pharmacokinetics of the drug, which means how much protein binding, so get familiar with these terms: protein binding, oral bioavailability. What do these terms mean? Okay. The other thing you want to be cautious of is high vitamin doses. So if there's a question that's related to excessive vitamin doses, you may want to pause and think about that, right? Whether or not that's the safest thing to do. The other medications you want to avoid is, in high doses, that is sedative drugs, opioid, narcotics. You also want to it is discouraged, any radioactive agents or chemotherapy drugs or high doses of iodine are to be avoided. So, I talked a little bit about this, but I just want to make sure to cap some of the things that are very important to understand. Drugs can transfer into milk if there is a high concentration in the maternal plasma. Remember, I said that's in the bloodstream, right? Drugs may transfer if there is a low molecular weight, less than 800 Daltons. Any drugs that have low protein binding, all of these drugs can really pass into the brain easily. Once it's in the milk, some of the drugs have the capacity to cross the blood-brain barrier. So you want to really be careful about when you're reading about certain medications, even looking at, for example, the pharmacokinetics, like, well, how does it work in the body? You want to be familiar, but for the sake of the exam, you want to be sure that you kind of understand some of these pharmacokinetic principles of how how medications enter into the milk. I don't know why I want to say milk before medications, so bear with me. Uh-oh, my screen just got bigger for some reason. All right, let me make sure that I said everything about that. Yes, next slide. All right, antibiotics. So before I start to go into the next few slides, I do want to make it clear that these are tables of medications. I'm not asking you to like remember any of these medications. Remember, like, it's an L1, an L2, an L3. The reason I put these here is so that, for example, with antibiotics, you can see that a lot of these antibiotics is ending in the word IN. So you got ampicillin, you got amoxicillin, cephalosporin, clindamycin. So you can see that if you get a question that has a medication, and you may not be familiar with that particular medication, sometimes part of the name, the prefix or the suffix can give you like, oh, that's what that is. So that's why that's there. The L category is just for you to really kind of understand that the most common drugs that are used fall within the category of an L1, L2, which is safe or safer. So safest, I should say. And so with that being said, the biggest things to know is that most antibiotics are acceptable. There can be some concerns, though, with regards to the infant's gut flora, as well as our own, and also huge issues with antibiotic resistance. I'm going to get my words together. Okay. And so that's why this is here. So if you're thinking about, if you get a question about antibiotic, they're fairly safe, but, what are some concerns? These are the concerns that you may need that may show up or may not. Okay. Something is happening to my screen here. Let me pause for some technical. Hold on.
Hey, Sekeita. Are you seeing the slide that says antifungals?
I'm seeing antifungals, but it looks like it's like not showing up all the way, like it's cut off. So, okay, I'm gonna roll with it. Here we go.
Got it? Okay, good.
Antifungals. All right. So antifungals, also, if you look at this one, I did just say that most drugs that end in IN are, right? Antibiotics, nystatin, mycostatin ends in IN, and it's an antifungal, right? And so really, if you were to see this is an antifungal medication, which means for things like yeast, it really is used for, or other fungal diseases. So also note that these categories are fairly safe. They're L1, L2. And so this is just giving you an example of, again, some of the common medications that may be used and for diseases or infections such as, like I said, yeast, which is an oral infection. And it's also important to know, though, that if an infant is perhaps diagnosed with thrush, it's important to know that the parent and the child should be treated simultaneously because the infection can pass back and forth if that does not occur. I think that's pretty much it on this slide. I am going to wing it because with all things tech, we learn how to wing it. But let me just be transparent and say part of the slide, like I don't know what's going on with my screen. So if there is something that you are having a question about regarding the slides or something that's on the slide that I did not mention, please ask the question. And in the end, I will answer it. Let me just say it like that, because I don't want you to miss anything. But I want to keep rolling with it because I value your time and I don't want to sit here and try to figure this thing out. Thanks, Angela. I think I got this. We roll with the tech issues. All right. So when we're talking about pain medications, pain medications come in, sometimes they are like a combination drug, sometimes they are just by themselves. One of the most one of the most common drugs that used to be prescribed was Tylenol 3. And Tylenol 3 was a medication that combined codeine as well as acetaminophen, which is, Tylenol. In essence, what was determined a few years ago was that it was the codeine that was actually the harmful part of it. So Tylenol 3 or any codeine drug would not be acceptable. However, acetaminophen is an L1 and it is acceptable. So making sure that you kind of understand the principles. Going on to another combination drug, which is really still being prescribed, is acetaminophen and hydrocodone, which is Norco. You look at that, you look at hydrocodone, it's an L3. And when we speak about these drugs, we're not talking about people who like abuse drugs or misuse them, right? This is use as prescribed. So I want to be real clear with that as far as the recommendations with lactation. Some of the concerns that can happen with medications that have sedating effects is that the infant can also kind of get some of that sedation and be sleepy or maybe have poor feeding. So these are some of the things to really, advise parents on. Parents shouldn't, these dosages should be short term, particularly opioids. They shouldn't be like 30 days on this medication, right? And so want to be clear about that as well. So with that being said, you just want to make sure that you understand like the benefit risk, like the benefit is yes, pain relief, but also making sure that we're watching the infant for sleepiness and poor feeding. That would be an indication. The other thing to look at is, for example, aspirin. And let me see, before I go there, no, I don't want to go there. All right, so aspirin is an L2. However, it is not safe to use when an infant is sick or has a fever because it's association with Reye's syndrome. And so you also want to be aware of that particular medication as well. And again, all narcotics should be used for a limited time. Anticonvulsants are anti-seizure medications. And so, for example, you may not see the word anticonvulsant, you may, but also in all of these slides too, think about your medical terminology. And I'm saying that from a standpoint that there are many people on the call who don't work in healthcare settings, right? You've taken the medical terminology course. You want to make sure that you kind of retain what those mean because the context of the question could mean a whole lot, right? When you are trying to answer a question. So anticonvulsant means like, okay, against seizures, no seizures. We don't want seizures. These are the common medications that are used. Now you look at Depakote, which is at the very bottom, and that's an L4. And so placing this in this slide means that this is one that you're like, wait a minute, what am I doing with this one? So the reason to have these categories in here is to really have a general idea about the medications and what some of the concerns are for the infant. So with the infant, sleepiness, poor feeding, or irritability are some of the things you want to watch for. Antidepressants, yes. So the concerns for the infants is sleepiness, poor feeding, low muscle tone, agitation. Um, the one thing I want to say about this too, though, is that these are some of the more common names that you will see. And again, as it relates to antidepressants, they are L2s. There has been some literature that's like some controversy about whether or not, you know, Zoloft or certain medications should be used. However, right now, it's important to remember the risk benefit ratio, right? Because depression comes with its own set of concerns. And so you want to really think about, really antidepressants generally. The ones that are listed here are usually the first go-tos, but also there are others. So keep in mind the infant concerns could be, withdrawal symptoms. If the parent is like just abruptly stop taking it, sleepiness, poor feeding, low tone, those sorts of things. And if you notice from the prior slides that I've talked about, almost all of the infant concerns, with the exception of the antibiotics, is the gut flora, is that there is poor feeding and sleepiness. So there seems to be a theme. And so putting this all together, hopefully that makes it a little bit easier when you're thinking about the context of the question that you may be asked. Antihypertensives, these are medications that are used for hypertension, for blood pressure, for high blood pressure, I should say. Again, looking at this chart, you're able to see that, most of these medications are safe. I am going to actually pull up my own PowerPoint so that I can see the slides. I want to make sure that I am covering everything because, you'll be playing this back potentially. All right, there we go. So
Got
now I
it?
have two slides going on here. All
Okay,
right, now
perfect.
I can see the entire slide on this other screen. So please pardon me as I look like this. Okay. All right. So the reason why it was important because I knew at the very bottom that I was going to miss this. I can't see hydrochlorothiazide and furosemide, but I knew that it was on this slide. So here you go. This is a medication that I have an asterisk next to. This is because it has the potential to reduce milk supply. Now, this is a diuretic medication, which means, well, I'm not going to go into to what it means, but I will say this is that it's used to kind of get rid of fluid, to get fluid off. So in saying that, it has the potential to reduce. And I just say potential, meaning that that's what the literature states. Infant monitoring includes the sleepiness, lethargy, pallor, and poor feeding. And again, if you look at this list of drugs, you will see that they are fairly safe medications. Looking at the atenolol, also looking at that little section, you see that there's L3 involved, and also Lasix is an L3. So in a nutshell, look at these medications also because what's in the name? You see nifedipine, nicardipine, you see labetalol, metoprolol, propranolol. So you can kind of look at, these can be indicators of what class of medication are they talking about, right? So this is to give you some hints and some ideas on maybe you've never seen that medication, but what is the end of it? What's at the end? And kind of link it like that. All right, getting to now the vaccines, and I'm going to tell you this people will have lots of chatter about the vaccines. And so when I use this slide, I usually go straight to what the book says, right? Because I want to make sure that of all the things that I really capture what the information is right now. Not saying it might not change, but also when you're thinking about vaccine safety, you also want to know and make note that this is a global exam. This is an international exam. And so, there may be recommendations that are specific to, your country, but I'm telling you what the general consensus is from the evidence. So here we go. So according to Lawrence and Lawrence, 9th edition, their breastfeeding guide for the medical profession, it states that the smallpox vaccination is inadvisable for the mother of an infant that is younger than 1 year of age, nursing or not. It is really the personal contact, not the breastfeeding, that causes the risk. Therefore, there's no advantage to weaning if the medication is necessary. And the other thing to note is this vaccine is not routinely given. It's really rarely indicated. However, it's still available. So there's that. There are some guidelines for this from the CDC, which is the Center of Disease. Um, and this is a US based. So you might see something that states it a little bit differently. And I'm just going to just speak on that just a little bit, but I don't think this level of detail will be on the exam. But I do want you to know, because some people will say, oh, she said it wrong. So the CDC advises against this vaccination during lactation. And if a mother is vaccinated with an infant younger than a year of age, physical contact between the mother and infant, whether the baby is breastfeeding or chest feeding or not, should be avoided until the vaccine site is fully scabbed over. So just want to make sure that, we do understand this is an international exam. However, there are some caveats to the smallpox and yellow fever. The yellow fever vaccine is not recommended. There have been 3 cases that have been associated with encephalitis, which is inflammation of the brain, have been reported in exclusively breastfed babies. So with that being said, that is also yellow fever is not recommended. I want to say that's it, Angela, unless I missed some things about the vaccination. Um, this was an interesting ride. Let's see if I can get in my slides after you go. So
There you go. Well, just real quick, somebody asked an interesting question, so I'll pop it in here real quick. What about doing, and this is an over-the-counter medication, which is found in the United States, something called Excedrin migraine, which has acetaminophen, aspirin, and caffeine. Amy has responded, but I thought it might be nice for you to comment here as well.
Yeah, so that is one of the combo medications. Usually, if you're looking at HELS, or there's also is it LacMed, the website? It does not exist anymore
Yes.
on an app that we were so fond of. But if you look, you will also be able to see, there's caffeine that has to be considered. So essentially, I'm assuming what the authors do is they kind of think about this from all of the pharmacokinetics, and I am sure that there is some type of way that they kind of combine it and make sure, and they do studies, and Hale does a lot of studies on these medications, but also taking into to concern that some medications don't have a lot of studies, but they do have properties. So they have these properties that tell us, like, for example, heparin has very large molecular weight, right? So that's one off the top of my head that I can talk about, that you would say, okay, there's no way that's even going to enter breast milk, right? So you really just have to use your resources. That is a great question. And that, again, is a combo medication. So thank you. I might put that on the slide the next time.
Yeah, that's a good point. Yes, we're always learning
Yes.
That's for real. As a matter of fact, Sekeita and I were reviewing the information about the vaccines, not long ago, because we found a new resource. And so we were both testing out this new resource in order to determine whether or not it was something to pass along to everyone. So we're excited to always learn new things.
So Angela, how did I do? Because I was like questioning some of the pieces, like, I don't know if I should say that. I don't know.
You're fine. You're firing on all eights, Sekeita. So it's all good.
Perfect.
So yes.
All right, take it away. Thank you so much.
Thank you. Okay, now we're going to talk about breastfeeding beyond the first month. And if you need more information about this, we actually do have an exam review course, as well as content on our on our website, lactationtraining.com. and you can find out more information on different specific topics, such as infant growth and development, breastfeeding the older nursing baby, and weaning, etc. So when counseling clients with older nurslings, be mindful that the number of feedings and time at the breast may fluctuate greatly. Babies might return to intense breastfeeding to adjust their parents' milk production as needed, which is sometimes referred to as growth spurts. They often occur around 2 to 3 weeks, 6 weeks, and 3 to 4 months. Developmental milestones may increase night waking and nursing. These little ones seem to be busy. They're just too busy exploring the world in order to spend any time at the breast. And they're worried they may miss something. Therefore, they're going to make up for lost time and wake up more frequently at night to receive the caloric intake they intrinsically know they need. Latch and positioning technique is considerably more flexible after the first few months. Note the picture here where the baby is further away from the breast than when a newborn. Unless the mother is uncomfortable, there's no reason to suggest changing the position or latch. Now, breast and nipple pain is something that we all will counsel patients with, and it's important. Those are two challenges that are important to have really good evidence behind. And on this slide, and this is also included in your handouts, is a link to a 13-page algorithm which was developed by the University of North Carolina for breast and nipple pain. It's a very valuable resource, and it's a nice review before the exam for how to identify many of the causes of breast and nipple pain. You can also find this on the website mombaby.org/UNC-lactation-program. Now, mastitis. Mastitis is an infectious process in the breast that produces localized tenderness, redness, or discoloration of the skin, and heat, where it actually feels warm, warmer than the surrounding breast tissue, together with systemic reactions of fever and malaise. Prospective studies estimate the incidence to be between 3 and 20%, depending on the definition and length of postpartum follow-up. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis, and to abscess if treatment is not promptly introduced. Symptoms include a fever of 38.5 degrees centigrade or 101 degrees Fahrenheit, chills, headache, flu-like body aches and symptoms. The breast is painful and swollen. The breast area could be red or discolored or hot and tender to the touch. You may notice some streaks or bruising of the breast tissue. So the best treatment for mastitis is rest, to continue to feed and or pump on the affected side, to use cold compresses to reduce the edema, creative nursing positions, some breast or chest movement or breast gymnastics, if any of you have seen Maya Bowman's amazing work. We want to support compliance if antibiotics are prescribed, and the use of analgesic or anti-inflammatory for discomfort, fever, and swelling. Now, I intentionally chose these pictures because I want to try to help you to see the mastitis. It can be challenging to note overt inflammation or redness on someone with darker skin tones. So that's why I chose this image. So recurrent mastitis, according to the Breastfeeding Atlas, Staphylococcus aureus is cited by Dr. Ruth Lawrence in her book, Breastfeeding: A Guide for the Medical Profession, as a common cause of breast infection. Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was found by other researchers in the milk of asymptomatic women. In the case of recurrent mastitis, a diagnosis can be made with a culture of the milk and the infant nasopharynx or oropharynx. Treatment options and a thorough discussion of mastitis can be found in the Academy of Breastfeeding Medicine's protocol on the mastitis spectrum. Breast abscess. So a small percentage of breast infections will develop into an abscess. Kinley et al. Reported the incidence around 5 to 10%, whereas Amir reported about 3% of women with mastitis in her sample developed an abscess. Now, there's one theory that healthcare providers are more educated in the prevention of abscesses. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment was delayed beyond 24 hours. So the definition of an abscess is a localized collection of pus that forms from an infection that has no opening for drainage. The indications for an abscess are the same as mastitis, although symptoms may be less severe because the abscess is isolated from the rest of the breast. This picture demonstrates an obvious abscess. Occasionally, an abscess can occur in the absence of any systemic symptoms. And note that when an abscess is more likely to form when antibiotic treatment was delayed beyond 24 hours. That's when the abscess rate increases. Treatment includes several different options for smaller abscesses, less than 3 centimeters. The recommended first line of treatment is fine needle aspiration, single or repeated, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter can be placed for 3 to 7 days with oral antibiotic effective against penicillin-resistant staphylococci for 10 days. For larger abscesses, the healthcare provider will incise and drain the area. A drain is placed to promote drainage. The incision heals from the inside out, usually within a week or 2. Now, a parent may continue to directly feed on one or both sides, depending on the location, associated pain, and medication. Although a very small percentage of women resume menstruation as early as 6 to 12 weeks, others may not menstruate until breastfeeding has ceased totally. It's usually dependent on the overall breastfeeding or chest feeding pattern. There's no significant change in the composition of milk. Hormonal changes may alter the taste of milk, which can prompt the baby to be fussy or to refuse to nurse. Some parents feel that it temporarily lowers their milk production. Now, the return of menses also can be a sign that fertility has resumed as well. Therefore, it may impact a family's child spacing plans, especially if they are relying on the lactation amenorrhea method. And one keynote, the lactation amenorrhea method is something which is utilized internationally, and you may want to be aware of the different parameters for LAM and when it is effective and when other methods may need to be utilized as well. Pregnancy while nursing can occur. It's important to explore the parent's feelings about continuing breastfeeding or chest feeding. Some people will note nipple and or breast discomfort first. They report the discomfort actually alerted them to the new pregnancy. Now, depending on the age and nursing relationship, some nurslings may be reluctant to wean. Mature milk will change back to colostrum around 4 to 5 months into the pregnancy, which may change the taste and quantity of the milk. Oxytocin is released during nursing. However, the oxytocin is blocked by progesterone. Therefore, there's no need to wean a nursing baby or child unless there is a true risk of preterm labor. There is limited data which shows an impact to the nursing parent's nutritional status by continuing to nurse through the pregnancy. Therefore, it is important for the parent to be mindful of their diet. Some older babies or toddlers may stop nursing during the pregnancy and resume after the birth. So tandem nursing is the term to describe breastfeeding of 2 or more children who were not born at the same time or are of different ages. It occurs when a parent nurses through pregnancy, or if a previous child weaned during the pregnancy, they may be interested in resuming. It's important to explore the parent's feelings about tandem nursing. As one of the pioneers in the lactation field, Shelley Marmette, once said, it takes the patience of Job to tandem nurse. If there's an issue with the infant's weight in the early days, ensure that the newborn is given priority at the breast or chest. Some parents will dedicate one breast to the newborn and the other side to the toddler, and then switch the next day. Note here the way the older sibling has their arm around the new brother. Granted, it may be so everyone can fit on mom's lap, but it may also be a sign of affection. If a parent expresses a need to wean, it's important to explore those reasons. Some families may believe that weaning may increase a child's independence or help a child to sleep more at night, which may not be achieved through weaning. Gradual weaning works best for both parent and baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer and don't refuse a child's request to nurse. Eliminate a feeding every 2 to 4 days, preferably not back-to-back feeds. Continue as both the parent and child accommodate the new routine. The nursing parent can hand express for comfort as needed. Change daily routines for the child so that alternatives to nursing are offered and explored. Offer other foods and drinks just before those regular nursing sessions, and to breastfeed or chest feed when asked, but for shorter periods of time. Those are all suggestions for how to help with weaning. Okay, now let's take a look and see if there are any questions that people have. Let's see. So yes, some people were struggling to see the mastitis. And so yes, you may notice the discoloration in the skin as far as the mastitis is concerned. There are apps for medication use. And actually, as I said, Sekeita and I found a new one today. So hopefully those are the questions for the moment. And so I will keep going and talk about milk supply. Okay, here we go. Now, many of you may be familiar with this diagram. It's a picture of the neuroendocrine reflex arc, just to remind us of the physiological mechanism of lactation. Milk synthesis is a complex interplay of the hypothalamic, pituitary, gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It is milk removal that enables milk secretion to continue. And yes, this slide is included in your handouts. It's one of my favorites. Now, this is a slide you may have seen in the anatomy and physiology, as well as in the relactation exam reviews. According to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes such as retained placenta or lack of pituitary prolactin. Glandular causes might be surgical procedures such as reduction mammoplasty or possibly insufficient mammary tissue. Postglandular would be any cause for ineffective or infrequent milk removal. Now, there are iatrogenic causes of lactation failure, which are those impacted by policies and procedures in a hospital or healthcare providers, which can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could also be included in postglandular. As I mentioned, postglandular could be any cause for ineffective or infrequent milk removal. Iatrogenic reasons for lactation failure include separation of the birthing person or nursing person and the baby, pacifier use, and as mentioned, perceived insufficient milk supply by staff or family, which leads to supplementation. Now, interventions which require supplementation and a milk supply which is not simultaneously supported through hand expression or pumping could be included in here as well. Consider the supplementation scenario. Parents are told that they have to supplement their baby. The parents may feel that breastfeeding has failed, and they're worried about starting up again. Well-meaning healthcare providers may not encourage that resumption if the interventions are effective. Common scenarios could include a baby diagnosed with hyperbilirubinemia in the early days after birth, and supplementation with breast milk substitutes is started, or a 2-week-old baby who wasn't gaining effectively, and they begin to gain with supplementation. Now, in both of these cases, parents may be afraid to resume exclusive breast or chest feeding or human milk feeding, And healthcare providers may not have the time to create that care plan to help the baby to return to the breast or chest and to remove that supplementation. So this is a unique situation where a lactation care provider can provide the sort of clinical care plan that this family needs in order to resume breastfeeding and chest feeding again. Finally, there are some cultural beliefs that create a barrier to normal breastfeeding, such as the colostrum not being enough or is somehow bad for the baby. So structural issues, which include surgical interruptions in the breast or chest, such as a biopsy, reduction or augmentation, a chest tube as a preterm baby or a thoracotomy prior to mammary development, mammary hypoplasia or insufficient glandular tissue, mammary asymmetry, including intramammary distance or the space between the two breasts. So chronic illness can also be an issue here. So we're talking here about hypo or hypothyroidism, lupus, Parkinson's, diabetes, hypertension, acute illness or birth-related complications, including hemorrhage after birth, especially causing a large sudden drop in blood pressure and or requiring a blood transfusion. So as a point of reference, 500 milliliters of blood loss is considered normal. A hemorrhage may cause damage to the pituitary, ranging from mild insult to major infarction. Sheehan syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the anterior pituitary. Hormonal issues include irregular menses, infertility, obesity-related issues, PCOS, weight loss surgery, specifically gastric bypass surgery, which can impact the amount of nutrient absorption. Other factors for delayed lactogenesis 2, which is greater than 72 hours, include premature delivery, insulin-dependent diabetes mellitus or gestational diabetes. Metabolic status or health refers to an interesting study from Namsen Rivers, Donnell, and Huang, which describes 3 risk factors for delayed lactogenesis: higher BMI, increased maternal age, and larger infant birth weight, as known correlates with carbohydrate intolerance and systemic inflammation. And we added fat-phobic bias and staff who are unaware of their bias and therefore do not provide the support that families need in order to get breastfeeding and chest feeding started. So other factors for the delay of lactogenesis 2 include hypertension, high levels of stress to the mother and fetus during birth. These include cesarean birth, especially when urgent, prolonged stage 2 of labor, which is greater than 1 hour, augmentation of labor with intravenous oxytocin, forceps or vacuum delivery. So things which can also affect the timing is the timing of that first breast stimulation following delivery. So either the baby at the breast or chest or the timing of first milk removal. Significant edema of the extremities, and endocrine disturbances. As you can see, there are complex interrelationships among various factors that can affect lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiological response due to delayed or ineffective suckling or a combination of factors has not yet been clearly identified. Early, frequent, and effective breastfeeding or milk removal appears to be the most important factor in establishing normal lactation. And I frankly think that it is that skin to skin and the milk removal in literally the first hours after birth as key factors to counter some of the possible risk factors. For those of you who work in a hospital setting, you can understand how that may be impeded with any of the above diagnoses. So any issues which affect sucking or suckling frequency may affect the initiation and calibration of milk production. And so let's take a look at the infant's role in this scenario. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors include gestational age, premature infants, of course. Remember that those late preterm infants may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy, any sort of tongue mobility restriction can impact not only maternal nipple discomfort, but also the ability to remove milk. Palatal issues obviously include partial or complete cleft of the hard or soft palate, but also includes a high, bubble, or channel palate, and airway issues, which include laryngomalacia or tracheomalacia. Long term, the issues on the previous slide can impact the initiation and calibration of the milk supply. The following can impact the maintenance of milk production, such as in that immediate postpartum period, the infant hypotonia or hypertonia, birth trauma, birth pain, such as shoulder dystocia or the use of forceps or a vacuum, cardiac or respiratory issues. Long-term impact can be infant facial anomalies of the tongue, of the palate, or sensory integration issues. So all of these can impact the milk production and are caused by the infant. Now, possible solutions. There are a few solutions to get off to a good start with building a milk supply. During the hospital stay, we want frequent skin-to-skin contact. Frankly, you can't overdo this. Frequent colostrum or milk removal. Hand expression does seem to work best. A quick note, for parents who are pumping for their premature infant or are having trouble extracting an appropriate amount, utilization of the other senses can help with the milk ejection reflex. A study noted an improved milk output when the parent was looking at pictures of the baby and or listening to the baby's cries or coos, as well as smelling their baby's t-shirt or blanket from the day before. Anticipatory guidance about normal newborn circadian rhythms is a helpful solution to some parents. Visuals of the newborn stomach and the nominal nutrition requirements in those early days. Realistic expectations. Alternative supplementation techniques if required. And of course, close follow-up. All right, I'm going to take a pause here to see if there are any questions that have come in. So someone is asking about the handout, and so we've only put key slides in the handout, and part of the reason is to protect the images which are on the handouts. Some of these pictures were gathered by lactation consultants. I'm actually one of the lactation consultants who donates their images, and so we have a relationship with the parent that we can provide their images, or we can utilize their images only within our webinars. And so that's the reason why we do not have all of the slides in the handout, to protect the parents. And so someone also mentioned that lactogenesis is now called something new. Good on you, great for catching it. It's known as secretory differentiation and secretory activation. And then there's also galactopoiesis. So there you go. Those are a few terms that may be there. Let's see. Anything else? No, but good on you to the, oh, go ahead, Sekeita.
I'm going to chime in, galactopoiesis and then involution. So
thank you. Good. Excellent.
We make a great team, Angela.
High five. Yes, we do. Yes. And good on you to the person who's here from Brisbane. I was just there last week. So yay. Nice to see you here. And also, I think we have Canada here and a few other places around the US as well. So yay. Glad to see you here. Okay. So I'm going to go ahead and move forward, and we're going to talk about research. So what are the different aspects of research to keep in mind? Now, this is not a full list, but I'm going to try to make it to the simplest points, so try not to be afraid. Now, the dependent variable is what the independent variable acted upon. For example, in a study of breast pumps, the volume of breast milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable, and the type of pumps is the independent variable. Now, consider what we know about the effectiveness of pumping. It can be impacted by a number of factors. Therefore, confounding variables in this example might be the privacy of the place where the parent pumped, and it also which may lower the amount that they're able to extract, or time of day could also be a confounding variable. So a confounding variable is, of course, that can confuse the interpretation of a study's results. And so that's why it's important to actually look and see in the methodology if some of those things were controlled. Okay, some frequently used terms. The standard deviation is a measure of how spread out the numbers are. So 68% will fall in that first standard deviation. 95% will fall in the first and second standard deviation, so you see in that blue there, and 99.7 will fall into the first, second, and third standard deviation. So there's only going to be a few in that fourth standard deviation. Now, statistical significance is the level of certainty in the results of a study. If we want to be 99% confident of our results, we set the significance level at 0.01. If we want to be 95% confident of our results, we set the significance level at 0.05, which is most medical research. Bias. Now, there are different types of bias, and it can influence research. For example, a piece of research which looks at the effectiveness of breast pumps, specifically the frequency of the number of cycles per minute. You'll note the university who supported the research is funded by a specific breast pump company. The researcher whose university receives funding from that pump company could be biased in their study design and or the interpretation of the results. Informed consent. What that means, that includes, subjects need to be informed about their rights, equipment, or medications used, procedures, confidentiality, and the ability and understand how to withdraw from a study at any time, as well as any rewards for participation. Okay, there's a little bit about research, and now we're actually going to go into our question time. So, Jill, I hope you're ready, but what we're going to do is we're going to ask you a few questions. Jill is going to put up the question. I'm going to show the question. We're going to keep the question on the screen for just a moment, so you can read through it yourself, and then we're going to open up the poll. And when we open up the poll, then you can decide. It's going to be multiple choice questions, so you won't have to type on your teeny screen if you're on a smartphone of sort. So we want to just, ask you a few questions and sort of see how you do. We'll leave the slide open for about 30 seconds and the poll open, for about 30 seconds. You answer to the best of your ability. Don't worry, it's not going to be graded, and we're not reporting these results anywhere else. We just want to give you a chance to practice here. So let's see, we're going to talk about sort of overall concepts here, not what is done at your facility in your country. So here we go. All right. So the poll is open, I see, so we're a little quick here. Let me go ahead and read this to you. So significant distance, physical breast presentation which may contribute to low milk supply is significant inframammary fold, a breast cup size which is greater than B, or less than B, helps to read all the symbols, significant intramammary difference, or hypoplasia of the superior breast tissue. So you can see the poll here. And so answer which one you think it is. A, significant inframammary fold. B, breast cup size less than a B. C, significant intramammary distance. Or D, hypoplasia of the superior breast tissue. Okay, we'll give you another few seconds here. Okay, great. We'll go ahead and close the poll. And so the response, the correct answer is significant intramammary distance. So that can be related to hypoplasia. The cup size doesn't matter. Hypoplasia of the upper breast tissue does not indicate insufficient glandular tissue. So that was the superior breast tissue. That's the upper part of the breast tissue. That doesn't indicate insufficient glandular tissue. Hypoplasia of the lower medial and lateral quadrants do, which is why the correct answer is C, significant intra-mammary distance. That's the space between two breasts. Okay, now let me go to the next slide and then we'll open the poll. I'll read it to you first. A postglandular reason for insufficient milk production is early introduction of hand expression, pacifier use, retained placenta, or previous breast biopsy with a periareolar incision. Okay, Jill. Go ahead and open the poll. So again, the question is a postglandular reason for insufficient milk production, early introduction of hand expression, pacifier use, retained placenta, previous breast biopsy with a periareolar incision. Another few seconds here. So this is a postglandular reason. Okay, great. Go ahead and close it out. So yes, the correct answer is C, pacifier use. So retained placenta is something which is a, oh my goodness, I just had a hiccup here. The answer is pacifier use. Retained placenta is not, because retained placenta is a glandular reason why. You know what? I'm slow here because I remember that I was kind of hesitating on this one as well. So the previous breast biopsy with a periareolar incision is actually a preglandular tissue. Retained placenta is a glandular tissue, and a postglandular reason is going to be pacifier use. And I'm going to slowly talk because I know if I've gotten it wrong, Sekeita or someone else is going to tell me. So I'm not hearing anything, so I'm going to trust that I got that one right. Okay, great. All right, next question here. While reviewing your postpartum patient's chart, you see they receive Pitocin, which is synthetic oxytocin, and Methergin after a vaginal delivery. You know this patient most likely A, experienced a normal blood loss, B, experienced excessive blood loss, C, gave birth to multiples, or D, will not be able to breastfeed. Okay, Jill, go ahead and open the next. So the names of the medications are here. So it's Pitocin and Methergin. I would attempt that word, the generic term, but I'm going to respect myself and not do that. So what do you think? Is this a normal blood loss, excessive blood loss? They gave birth to multiples, or they won't be able to breastfeed? Okay, good. Go ahead and close this one, Jill, because we didn't fool anybody on this one. And so yes, this person did experience an excessive blood loss. So yay, most of you got it correct. Okay, good. Let's go to the next question. Lilo, lactation consultant, did a study in her hospital. Families were randomly placed in two groups. One group received an intervention and the other group received standard postpartum care. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Okay, great, go. So what sort of research is this? What type of research is this? Is it quantitative, qualitative, historical, or epidemiological? I'm gonna have a sip of tea. Okay, this is a good one. All right, Jill, go ahead and close it out. So the answer is A, quantitative. It is based on data. It's not experimental, and there's no attempt to determine causality. Okay, good. Going to the next question here. Oh, here we go. Oh, there's the explanation. So qualitative research is exploring real-world context based on perceptions, considers multiple perspectives, no attempt at causality, and the use of interviews and observations. That's qualitative. Quantitative research is experimental research to discover causal or correlational relationships between variables It's based on data collection and analysis. So that's the difference between the two. Okay, we're going to go back to LELO here because they're a busy person in their facility, and they did another study where they surveyed parents about their satisfaction with breastfeeding and what problems they encountered. What type of research is this? So again, is this quantitative, qualitative, historical, or epidemiological? So a survey of parents about their satisfaction with breastfeeding and what type of problems they encountered. So what sort of research is this? Gonna guess I'm not gonna fool anybody on that one. Okay, that's good, Jill. Go ahead and close it out. So yes, the answer to this one is qualitative. Most of you got it correct. And historical is one of those sophisticated distractors. In other words, because it's asking parents about, historically, what did you encounter in the hospital and what type of problems did you have and what was your satisfaction about it? So then one would assume that it could be historical, but no, it's actually qualitative. And remember, just to review here, qualitative research explores real-world content based on perceptions, considers multiple perspectives, no attempt at causality, so it's just asking what your opinion is about it, and we use interviews and observation. Okay, next question is iron levels are low in breast milk. What recommendations should be given to parents? A, supplement with iron drops until the baby begins solid foods fortified with iron. B, breastfeed, no supplementation needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in the parent's diet to increase the amount of iron in the breast milk. Okay, let's go ahead and go. What would you suggest for this family? Because iron levels are low in breast milk. What recommendation would you provide? Supplement with iron drops. Breastfeed, you don't need to supplement with anything. Start at 6 months. Or increase the amount of iron in your diet so that the baby gets more iron through your milk. Okay, this was a good one. Almost everybody voted in this one. Thanks. Okay, go ahead, Jill. So the correct answer is C, to breastfeed and supplement at 6 months with iron fortified foods. So what's interesting is that additional intake of iron by the parent will not increase the levels in the breast milk, even if the parent is anemic. And iron supplements taken by the parent could produce constipation in the baby. And anemia in the nursing mother has been associated with a poor milk supply. So that's an interesting little piece here. And so supplementing the parent with additional iron doesn't necessarily work. And the reason why is because the parent's body will actually synthesize the amount of food that's consumed, the supplements that are consumed to produce, the milk to the baby, which is exactly what the baby needs at that time. So the parent's body is going to mitigate it, is going to change the amount that's eaten to make sure that the baby receives what they need. So that's the reason why. Okay, great. Now vitamin D. So babies should be supplemented with vitamin D until they're, here I just gave you the answer. Just read the wrong thing. Oh well, here we go. Vitamin D levels are low in breast milk. What are the current recommendations? A, supplement the baby with vitamin D until solids are started. B, breastfeed, no supplementation needed. C, breastfeed and spend about a half hour per day outside. Or D, baby should be supplemented with 400 IUs of vitamin D daily. Okay, go, Jill. Even though everybody's going to get this one right. About vitamin D levels in breast milk are low, so what should we do with the baby? Should we supplement the baby with vitamin D until solids are started and then just stop? Breastfeed without any supplementation? Should they be supplemented with 400 IUs of vitamin D daily? Or spend a half an hour outside, let the baby get a little sun, see how that works. What would be the recommendations from, let's say, the World Health Organization? If you're not sure, if you know of your national organization which may have one thing, what would the World Health Organization say? Okay, Jill, you can close this out. Great. So the correct answer is actually D. Babies should be supplemented with about 400 IUs of vitamin D daily, not about, but that amount. And so what's interesting is that the World Health Organization actually states, and I quote, "There appears to be consistency across the world that newborn infants are at an elevated risk of vitamin D deficiency, and that a vitamin D supplement to exclusive breastfeeding is highly recommended in the primary prevention of vitamin D deficiency and rickets." So the World Health Organization is clear. I know that there are some suggestions to have the baby go outside under a shaded area and receive a little bit of sun every day. What's interesting about that recommendation is that it doesn't control for the latitude as far as where in the world that baby resides, nor the skin tone of the baby, nor anything else. And so that's why it is not recommended. And you do need to continue to supplement with vitamin D, and until solid, we do need to continue to supplement the baby with vitamin D after vitamin D is started, or after solids are started. And the reason why is because we want to make sure that the baby is receiving an appropriate amount of vitamin D, regardless of what they're being provided. Because if they're being given something which isn't high in vitamin D, then again, there could be that gap, and the baby could be at risk for vitamin D deficiency. So we do want to continue that even after they start solids. Okay, now here's a picture. So I want to ask, how old is this baby? And I do want to give you a few hints here as far as what you're looking at when you're taking a look at this adorable baby. So we notice here that the baby has a social smile. We notice that the baby can lift their head at about 45 degrees. They can hold their head up for a few seconds at least to take this picture. And the baby is visually searching to locate familiar faces or a sound. So is this baby 2 weeks old, 4 months old, 2 months old, or 8 months old? What's the most likely answer to this question? So now that you have that baby's picture in your mind, Jill's going to open up the poll. So is that baby 2 weeks old, 4 months old, 2 months old, or 8 months old? And so remember that if you say, well, it's either this one or it's that one, I don't think it's this one, the two that you're trying to decide between, one is the correct answer and one is known as a sophisticated distractor. I mean, since no one is choosing, for example, 8 months old, you know that one's not it's a distractor, but it's not a sophisticated distractor. Okay, great. Go ahead and close it out, Jill. And so yes, this one is a little bit of a tougher one. So half of you, you pretty much are split half and half. And so this baby is actually 2 months old, and it is tricky. I agree with you that this one is a little tricky because, and IBLCE hopefully won't have any questions like this, it's a little tricky because that head holding behavior could be for a 2-month-old or for a 4-month-old baby. And notice how the baby's hands are clenched, and notice also sort of the level of the camera, that the camera's super low, which means this baby can probably hold their head up for just a few seconds and then it may plop back down again. If it were a video, this would be so much easier and you'd know this baby was 2 months old. And so yes, this one is a little bit of a more challenging question. And so it's important to take a look at all of the different cues in the image. Remember, this will not be given to IBLCE, or we are not going to take any toll of this. So whether or not you got that question right, just a little practice. Okay, now we're going to our next question. Which of the following viruses is most likely to be transmitted to the infant through breast milk from an infected parent? A, hepatitis C, B, herpes simplex virus, C, varicella zoster virus, or D, cytomegalovirus. Which one of the following viruses is likely to be transmitted to the infant through breast milk from an infected parent? Hepatitis C, herpes simplex, varicella zoster, or cytomegalovirus? So this one is a good one. People are really thinking about this one, which is good. Okay, great. Go ahead and close it out, Jill. So the correct answer is D, cytomegalovirus. So it occurs about 60 to 70% of breastfeeding diets where the breastfeeding parent is infected with CMV as well. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complications from CMV infection, and there is debate about whether these infants should receive CMV positive breast milk. So if there's a debate, then if there's no clear-cut reason why, then chances are that question is not going to be on the exam. Can't guarantee it, but just know that there is a debate about whether these infants should receive this CMV positive breast milk. Herpes simplex virus and hepatitis C are unlikely to be transmitted via breast milk. And the varicella zosters virus, which causes chickenpox and zoster, infected parents should be encouraged to breastfeed. The infant should be protected from direct contact with any skin lesions. Okay, here we go. Next question is related to the parent's diet. So Tyler is vegan. What would you suggest to ensure adequate nutrition for Tyler and the baby? Protein from beans and rice, minerals such as magnesium and selenium from grains, folate from dark green leafy vegetables, or B12 from fortified foods and supplements. So what would you recommend for a vegan parent's diet? And vegan means that the person does not eat or consume any animal products. Animal products include, of course, the meat of the animal, but also any products such as butter, dairy, any dairy products, cheese, drinking milk, things like that. Okay, well, I think we have a lot of people who are familiar with the vegan diet in the audience today because, go ahead, Jill, most of you got this right. So yes, the correct answer is D, B12 from iron fortified foods and supplements. So they just need to make sure, a vegan parent needs to make sure that they're actually receiving an adequate amount of B12 themselves. Okay, good. Next question. The primary reason for providing human milk to premature infants is, so primary reason is improved bonding between breastfeeding, chest feeding parent and baby, assure continued breastfeeding or chest feeding after discharge, significantly decrease the risk of necrotizing enterocolitis, or improve neurological outcomes. Okay, what is the primary reason for providing human milk to premature infants? Primary. So I think with this one, we actually have a lot of these distractors, a lot of the other answers, the wrong answers are actually pretty good. This one is tough, but I don't think we're fooling you. Okay, Jill, good. So yes, the correct answer is to prevent the risk, or to decrease the risk of necrotizing enterocolitis. So indeed, while bonding, assuring continued breastfeeding or chest feeding after discharge, and the neurologic outcomes are all important, the primary reason is to prevent NEC. Okay, a potential risk of skin-to-skin care in newborn infants includes respiratory instability, sudden unexpected postnatal collapse, also known as SUPC, hypothermia, or sudden unexpected infant death, SUID. Okay, what is a potential risk of skin-to-skin care in newborn infants? Respiratory instability, hypothermia, SUPC, or SUID? The risk of skin-to-skin care in the newborn? What do you think? Okay, good, Jill. So the correct answer is B, sudden unexpected postnatal collapse. I would suggest that you know a bit about sudden unexpected postnatal collapse. It is something which is, there's still a lot of research which is happening with it, but that is something which is of concern. There are there's several clinical practice guidelines as well as best practice and research around this topic of sudden unexpected postnatal collapse in the early days, which is exactly when it happens. And so indeed, that is the correct answer. Hypothermia is a baby being too cold, and that is not a risk of skin-to-skin care, especially if you place a blanket behind the newborn and over the newborn in order to ensure that the baby stays warm. And respiratory instability is actually the opposite. The skin-to-skin contact actually improves respiratory stability. And sudden unexpected infant death is different than sudden unexpected postnatal collapse. And there's a couple of slight differences between the two, just to make you aware. Okay, here's another picture question. This hand technique, so notice the hand technique. This hand technique is used for all infants except premature infants, Down syndrome infants, neurological impairment, and infants with type 3 ankyloglossia. So the hand technique is useful for all infants except which ones? Where is this not helpful? Premature infants, infants who have been diagnosed with Down syndrome, neurological impairment, or infants with type 3 ankyloglossia. Give it another few seconds. Okay, Jill, go ahead. So yes, so remember, best practice is not to have negative stem questions. That said, this is a negative stem, and so that's why I'm glad all of you were aware of it. The correct answer is D. So this is known as a straddle hold, so you can see the baby is facing the parent, and you can see both arms, one arm on either side of the, thank you, Jill. One arm is on either side of the parent, the breast or chest, and the baby is doing, this hand position is known as the Danner or dancer hand position. And so what this does is it actually supports the baby's cheeks. So this is helpful for premature infants who are having a difficult time maintaining suction. It's also helpful for Down syndrome babies, or babies diagnosed with Down syndrome, because it actually provides support if the baby is slightly hypotonic. And neurologic impairment as well. So if there's any neurologic impairment, this can be helpful. So the correct answer is D. This hand position and the straddle hold is not necessarily helpful for infants with a type 3 ankyloglossia. Okay, good. Last question. Here we go. The World Health Organization guidelines for preparing powdered infant formula recommend boil the bottles and teats for 20 minutes, a rolling boil. Boil the water used for mixing for 20 minutes, a rolling boil. Mix the measured amount of powdered formula and hot water to 70 degrees centigrade, which is 158 degrees Fahrenheit. Or D, store prepared bottles in the refrigerator for up to 72 hours. Okay, so what is the correct answer for the WHO guidelines for preparing powdered infant formula? Do you boil the bottles and teats for 20 minutes? Do you boil the water used for mixing for 20 minutes? Do you mix the measured amount of powdered formula and hot water with the specifics of 70 degrees centigrade or 158 degrees Fahrenheit? Or can you store prepared bottles in refrigeration for up to 72 hours? What does the World Health Organization say? Go ahead, you can answer. See a few of you are hesitant on this one. Okay, good, Jill, go ahead. So yes, the correct answer is C. You want to mix the measured amount of powdered formula and hot water to the temperature of 70 degrees centigrade or 158 degrees Fahrenheit. So while you do need to boil the bottles and teats before you actually utilize them for the baby and allow them to cool, it's not for 20 minutes. And yes, you do need to boil water used for mixing, but it's not for 20 minutes. It just has to get up to that temperature and then it pops off. So a lot of parents will use a tea kettle in order to prepare the water for the infant. And you can store prepared bottles in refrigeration for up to 24 hours, not 72 hours. Okay, so Sekeita, should we answer questions now, or do you want to go ahead and move forward?
Yeah, I think we need to answer this one particular question before we move forward. And so this question is about HIV. And the question states, I understand in the US, we discourage it, but in other countries, it is allowed. With that being said, no. With this being an international exam, how would we answer this? So I'm going to answer this by saying the World Health Organization really has the guidelines. And what they essentially state is that in higher resource countries, it's discouraged, but in low research countries, it is actually recommended. Um, so with that being said, the one thing I do want to encourage people is to really look at the World Health Organization guidelines. And that's kind of perfect because Angela put here the World Health Organization guidelines for preparing powdered infant formula. The reason being is that the water sources in certain places may be more dangerous. And now we can even say that in the US in certain instances, like what happened in Flint, Michigan with the lead, right? So in saying that, you do want to make sure that you capture things from this global lens as far as what the recommendations are across the board. But when you think about a question that may be related to HIV, it could say something about a lower resource country or a higher resource country. What are the differences? Angela, anything to add?
Well, I want to add actually that the United States is actually moving on this point. And so, the exam is written, has been written a while ago. It wasn't written yesterday, and it wasn't written this year. It was written a while ago because it has to be translated and everything else. And so there's a lot of process that IBLCE has around this. And so that's the reason why, yes, go with the World Health Organizations always. And we're really excited that indeed that there are some higher resource countries who are starting to shift their recommendations, and especially on this topic. So that's something which is good. So I see another question here. Is the dancer hand position or the cheek support that isn't good? So the dancer hand position provides the cheek support, and someone said, well, if there's tongue restrictions, wouldn't the additional cheek support be necessary? And it may not be necessary. In other words, the baby may be able to maintain the suction with their cheeks with compensatory actions, but it's the tongue that needs to be addressed, not necessarily the cheeks. And there's nothing that we can do externally to the mouth in order to compensate for that tether in the more posterior aspect of the tongue. And so that's the reason why that's not the correct answer. Of all of those answers that you noticed, that would be the one that's the least likely for there to be any advantage to using the dancer hand position for that additional cheek support. Okay,
All right.
else.
If we could move on, Angela, in the interest of time. I know we said, this was 90 minutes. I do want to capture folks who may have to jump off, who only plan their 90 minutes with us. I am going to say, grant me grace. I'm going to not speak as fast as I normally would, but I am going to speak, in a way to honor your time. So with that being said, keep answering your questions in the chat. And yeah, we hope to get to them. So exam day survivor guide is so important that you really just take a moment right now to just breathe, right? To give yourself a hand. You made it to this today. You made it here to really prepare or see how prepared maybe you are for the exam, right? With that being said, you don't want to think about, all the passion that you've used, the dedication, the endurance. You want to take that with you. And you want to be sure that you remember that the day of, right? Because it's so easy to get so anxiety ridden that sometimes we're like startled by it. So in saying that, we just want to honor that you're here today, like really preparing and being intentional. Some exams are less than 30 days. And so if you've had the opportunity to identify any challenges, please, 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 work on those challenge areas. Get that room for growth so that you can really see that you are going to show up at your exam just as passion fueled, just as dedicated, and yeah, you're going to get through it. So in the last few days, stay connected to why you're here at this point. It's easy sometimes to get distracted the closer we get to the test date. Stay committed. Just keep thinking, going back to that passion. You want to really be able to ask yourself, do I trust in the preparation that I've done? If you can say that right now, like I trust my preparation, then yeah, take some easy breaths. But if you can't say honestly, whoa, I really trust that I've prepared myself, then continue on your journey for preparing. And yes, remember, breathe deeply. I'm a firm believer in taking that breath. Again, Angela just went over several questions. If you did not do so well on those questions, yes, take some easy breaths now and just say to yourself, yep, I'm going to tackle this. These are the topics that I'm having to struggle with, and I'll work on these things. Before the exam, you do want to make sure that all your things are in working order. And I'm going to go over a few things, whether or not you're taking it in person or whether or not you are taking it remote proctor. But what I will say is that, if you are going to be taking it regarding on live proctoring in a computer system, you need to make sure that you are following every single rule, that you know the rules, and that you're not at the last day wondering why you can't test on a tablet, for example. You want to make sure you are also testing where the internet connection, there's going to be, we can't prevent anything, but we want to minimize the 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 risk of being disconnected. So there's also security measures that you have to go through in order to test. And so you really want to go into the test understanding when breaks occur. You want to have this because you can be terminated or disqualified if you're doing the proctor, the live, the online version of the test. And so I'll talk a little bit more about some of the stipulations, but really just wanted to make sure that before exam day, you got this. Your computer system, this also is included in your handout. This is, when I say checklist, this checklist is very expansive. It takes you step by step by step on what you need to do to test your systems to make sure that on test day you're not going to have any issues. It also really guides you. Like, for example, if you're in the test and something happens, if you have technical difficulties, what are you supposed to do? And I'm talking about, again, if you're doing the remote proctoring, you're going to be live, there's going to be someone watching you. And so you do want to make sure that you know what to do should you have should you experience technical difficulties like I did earlier today, right? You want to wing it and keep going, but in some instances, you don't know what winging it looks like on this particular test. Like, this is a very important test, so make sure you know that. If you are testing at a testing site where you're going in person, there is also a checklist for that as well. This is also included in your handout. You do want to make sure that you wear a mask. As of when Angela and I were looking this up, we always make sure we're keeping up with the latest. Masks are still required at the local testing sites. And, if you're unsure, if you've heard something else and it's just an issue of contention, then maybe call the testing site, the test center where you're supposed to be taking the exam and inquire further. But as of now on the website, it says masks are required. All right, so your exam temperature, I alluded to this just a few minutes ago, but you want to really think about your temperature. Like, how are you feeling? Literally, like right now, how are you feeling? Um, and you want to also ask yourself, what's worked for you in the past? So if you are maybe feeling like, wait a minute, I'm not really prepared, ask yourself, what methods have you been using to study? have those work for you in the past. Maybe they're not working. Maybe there's a new something new to incorporate into your preparation. But really think about your exam temperature. If you feel like you got a good handle on it, great. But if you don't, do a self-reflection of what you've done in the past when you have been successful, and what you've done in the past when you maybe weren't so successful. All right, this is a quote that I love, and it states, "Many students cannot pass their exam because they fail to sacrifice the minimum capital of time and money." And the capital of time is important. We don't think of our time as capital, right? But time is money, is another way of saying that. And so spending the time to really put in what you're hoping to get out of the exam. All right, so it's important to know that before exam day, you have to be completely alone. So before you get to the exam day, make preparations. Look around in your home or wherever you're going to be sitting to take the exam. And this is only if you are taking it with the live remote proctoring, but plan to be alone. You can't have any pets in the room. There are no people that can enter the room. You should be in an area where the internet is strongest and that there's good lighting. And if you are at home and you have other people on your internet, you want to make sure no one else is streaming, no one else is on social media. Like, for the 4 hours that you'll be sitting, no one should be on the internet but you. Some of the other things that you can consider is hardwiring into a Ethernet directly into the system to make sure that you minimize the potential of connectivity issues. And you want to make sure that you have quiet time. You want to make sure that, say for instance, you're taking it at home and you may have dogs or some animals or children. You want to make sure that if somebody falls or if somebody rings the doorbell and the dog goes crazy, you want to make sure to think about ways that you can minimize, so that you can really have the time to answer your questions and to really be able to be of sound mind without worrying about what's going on outside of the testing area. All right, some of the other things that I know I found helpful, other students have shared with me that they found it helpful, is really thinking about this exam with the intention of what is it about you? What is it about all of this making you feel good? Regarding what can you do to kind of refill your bucket? Because sometimes when we study, we get depleted, and I don't want to give the impression that you know um, we don't have other things in addition to studying, right? So some of the things that can help to calm your nerves, especially because it's right around the corner, is to kind of create a playlist, an inspirational playlist. There's a couple songs. I will say one song, "I'm Every Woman," is a song. I have a whole playlist that when I want to feel like I am like confident, there's a whole playlist for that. It's called my confident playlist, right? So create one for yourself. I think it helps me when I'm feeling that way. But also you can find a podcast that kind of takes away some things. For example, if you've been entrenched in studying and you want to take a laugh break, because sometimes we need to laugh so we don't cry. So find a comedy, just take a break for a minute. And then the other thing you can do is all over your house, this works for some people, is to write yourself love notes. And what I mean by that is notes that say, yep, I got lactogenesis too. I know that is, it translates to this. This is when this occurs. You can write things all over your bathroom, your mirror, so that you're reminded that you got this, you can do this, and you've prepared for this. All right, the night before the exam. You can try to cram if you want to. I one of a lot of the leading experts say to just find your inner calm. Whatever you know, be confident that you know it. Take some time to just kind of relax. That wouldn't be the time to just stay up cramming all night long when you know you have to be at the testing center at 9 o'clock, right? So really find your inner calm, and hopefully before the night before the exam that you've gotten everything that you need to study, that you are confident in yourself and your ability to pass. Now, when you wake up the next morning, that is not the day that you want to experiment. You do not want to eat something that you've never had before in your life. Or you don't want to eat something that you know is really good and it messes with your stomach, but you no, eat whatever it is that is going to help you feel settled and that you're not going to have any issues. Also, comfortable clothing. Even if you have to go out to a testing center, for example, you want to make sure that you are dressed appropriately, meaning, do you need to be worried about the temperature? And again, the exam is international, so it's going to vary no matter where you are. The test is 175 total questions. It is administered in 2 parts. There's multiple choice, and then there's images. The images will also be multiple choice. You gotta, and the idea of some of the images, what they're going to be asking and what they're going to look like, maybe. So you really want to make sure that you kind of understand that, yes, there are images, but you will have to be choosing from a set of answers that reflects the actual image in question. The exam is scheduled for 4 hours. Sometimes there you can get 30 minutes extra time if the exam is not in your primary language, or if you have special circumstances. However, that has to be approved prior to exam day. So if you need extra time, that is something that absolutely has to be approved. There is only one correct answer for every question. There is no penalty for a wrong answer, so please answer every single question. It is to your advantage that every single question is answered. All right, exam strategies. I want to preface this because sometimes we make light of our shorthand, we make light of today's texting language, we make light of, just how we have adapted our communication over time. With this, and sometimes we will skim things. And that's why I'm saying that. You want to make sure you read each question. You read every single word, you read it slowly. And then you think about what is the first thing that you would do. Sometimes in certain questions, there's 2 answers that could possibly be, but you want to think about what the question is asking you. And if it's asking like, what's your next step? You think about what is the next step? What is the first thing? You also want to eliminate obvious wrong answers. So if you come to a question and you really like, you're toggling between 2, eliminate, or toggling between 3, eliminate and then choose. Watch for, again, Angela talked about this earlier, negative STEM questions. And again, remember, this is an international exam and it's an entry level exam. So you want to keep that in mind. All right, you want to work at a comfortable pace because this is a time exam. Mark any questions. There is a section where you will be able to flag the question and go back to it. So if you do get caught up, answer it. Don't leave it unanswered. Answer it, flag it, and make sure you move forward. And if you have time, then go back and go over your flagged questions. First impressions. It is so important to resist the urge to second guess yourself. Some of the scholars say that usually your first answer is correct. I know for me, I've had instances where I've taken a test, had the correct answer, second guessed myself, missed the question, and was so upset with myself after the fact that I knew the answer, but I just didn't have confidence. So when I talked about building your confidence, that's one of the reasons, is because sometimes we get into the test and our confidence start to wane. Don't read into the situation. These questions are not intended to trick you. It might seem like it, but it's not, right? So don't read into it. It's easy to get a question and then we say, but what if But what if they did not put it in the question, they're not asking you about that. Answer the question based on the information that you were given. All right. I don't know why this slide is empty, but let me go on to this slide that I can see. There we go. Okay. All right. So immediate termination or dismissal. Believe it or not, people have still, maybe they didn't attend this, I don't know, but anyways, or they didn't look at the checklist, but you cannot leave the exam workspace. And if you are, you may have a permitted break, particularly, between parts 1 and 2 of the exam. But even if you get to the end of part 1 and you are doing live proctoring, you have to check in with your proctor. You can't just say, oh, part 1 is over, let me go and grab, or let me go take a bio break. So you really must understand that. Before moving away from the web camera, and after finalizing, those are 2 you have to let the proctor know. Leaving the view of the webcam without acknowledgement from the proctor will basically say, okay, you're dismissed from this exam, you're disqualified. And unfortunately, I've been aware of a few times that this has happened. And so this is not a joke for real. Like you're sitting there like, really? Yeah, really. All right. There's no third party person, or again, dogs, cat, anything enter the room. That is another reason to be terminated or dismissal. Turning off your computer or turning off lighting or turning your computer audio off, those are also reasons. If you speak to anyone else in the room, or I'm assuming speaking, unless it's the proctor, that's another reason. So for these stated reasons, it's so important to go over those checklists that have been provided for you, so that you will really have an understanding of what is expected of you during the day that you are testing. I'm gonna take a breath for y'all, right? There are some people who are going to be like, I love this picture of this little girl, and it's like, did she set the house on fire? Because it looks like she did. But that's how some people are going to leave the exam, like, yeah, I did. I lit that exam up, right? There are some people who are just going to walk out like, I did it. Okay. The little guy that's so confident, like, my work here is done. My work here is done, and I will be an IBCLC, when they release the results like 10 million years later. That's a joke, right? It's not 10 million years, but it does feel like that. It always seems hard, right? But you can rest assured that you are done. You've done your best. And it's time to focus. It's time to think about what your next steps are. Try not to get caught up in when are the test results coming? When are the test results? That's another way to increase your cortisol levels, which is not a good thing. So just rest assured that you're done. You've submitted it. Some people will sit there. They finish the exam in 3 hours, and they would just sit there and not submit it because they're afraid to. If you are confident that you've done your best, submit your exam and wait for your results. And while you're waiting, the constant thinking about the exam is going to eventually just fade. Try not to, again, be obsessive about checking the website, and just, again, stay connected to your new professional community, or get connected to your new professional community, and keep learning. And what I mean by that is get connected is sometimes, and because the IBCLC this is again, people from all over the world, you may not have as many lactation professionals in your area, but it's important to kind of seek them out, find them, make relations, and also keep learning. If you are able to join, for example, a coalition in your area, or you're able to join a professional organization, that will keep you growing in your knowledge and the new evidence that comes out about this profession. So thank you for joining us. Angela, Do you have any words of wisdom other than remember your why? Like, I think we all, whenever I remember my why, it's so meaningful to me why I decided to do this journey. And so remember your why, keep yourself grounded, and I'm sure you will rock the exam out.
I agree. Not much more to say besides that. So this is good. I'm just checking out the questions, see if there's anything else. Kim and Jill and Amy have done an amazing job answering everything. So asking, people had questions about whether or not 2 IDs are required. People are asking questions about their jewelry, especially, gauges and things, piercings and such. So indeed, a lot of good questions. I do recommend that you go through the IBLCE documents. They're very helpful. They really are. Do read through them. I would caution folks against reading some of the stuff on social media. This happened to me or this happened to me. Just really stay focused. Read the information that comes from those trusted sources, and go directly to it. Sekeita and I even go directly to it. We're not going to do any interpretation. Some of the things that we may say can be from our opinion or what we've heard from others, but is that the actual truth or the actual information from IBCLC? Maybe so, maybe no. So that's why it's important to go straight there in order to try to figure this out. So
Yeah, I
anything
do want to
else?
say, yeah, because we used to include in our, in this exam review, we used to include the computer recommendations, the camera recommendations, all of those things. When I say to read the checklist, I'm not saying that lightly. If you do nothing else, read those checklists. Your computer has to have specificity. It has to be specific. I am not a tech person at all. Kudos to Jill for being here with us because we can't do this without Jill. So so in saying that, there is certain criteria that your computer has to meet, and you want to be clear on that. And giving you that information, like putting it all on the slides, sometimes that may kind of handicap certain people because they're relying on us to give them everything, right? But this is too important, and you have to do your readiness checks. And that's why we put those links there for you to be able to access the information that you need.
Right. Because that information, you reading the information, incorporating that information, that's what's going to help you to pass the exam. It's what's going to help you to be a really good IBCLC. So thank you very much for joining us today. If you have any questions, you can always reach out to support@lactationtraining.com. If you need even additional resources, we do have our exam review enriched, as well as our exam review basic courses, and we also have 125 questions, which we've translated into Spanish on our Capacitación en Lactancia website as well. So thank you very much for joining us today. It's wonderful to see everyone from around the world setting their alarms and participating.
Yes, thank you so much. I feel like there was lots of questions. I also want to thank Amy, and is it Kim that's helping us out today with
Amy,
answering
Kim,
these
and
questions?
Jill, yes.
Yeah, and it's been really a good group. So good luck to you, best wishes, and please don't hesitate to reach out.
Bye, everybody. Thank
Bye.
you.